Good morning to all. We'll be starting with the cornea update, that is navigating the curves, problems and solutions in keratoconus. I invite our first speaker, Dr. Anu Malik, from Blurred Vision to Clarity, Contact Lenses in Keratoconus.
Good afternoon, everyone. I'll be speaking on contact lenses in keratoconus. So there is probably no other disease to which eye subject hitherto so rebellious to medicine, so intractable in its nature, and at the same time so fatal to vision as conical cornea, and the pathology and treatment of which are so little understood. Coming to the prevalence and incidence of keratoconus, it has been estimated to be between 0.2 and 4,790 per 1 lakh persons and 1.5 and 25 per 1 lakh persons per year. So contact lenses for the treatment of keratoconus were introduced by Adolf Fick in 1888, and they improve vision by means of tear fluid filling the gap between the irregular corneal surface and the smooth regular inner surface of the lens. So fitting contact lenses can delay or obviate the need for keratoplasty also. And keratometry and corneal topography guide us in selecting the parameters for initial contact lens trial. The steeper the cornea, the more challenging it is, and the longer chair time and multiple diagnostic fitting trials are needed. So contact lenses can be soft contact lenses, rigid gas permeable, hybrid lenses, scleral lenses, and piggyback system. In soft toric lenses, we have Ocuflex toric, soft K, hydrocone, and in specialized rigid lenses, we have rose K, piggyback, mini scleral, and scleral contact lenses. We also have prosthetic replacement of ocular surface ecosystem, that is PROS device. So according to shape and position of the cone, it can be nipple cone, oval cone, or globus cone. For nipple cone, we require diameters of 8.5 to 9 millimeter, and for oval cone, a larger diameter contact lens is required, usually more than 8.7 millimeter. And globus cone are the largest, and they involve more than 75% of the corneas. Then they are the most challenging type to fit. Soft toric contact lenses are indicated in milder ectasia, minimal irregular astigmatism, and they are better tolerated and more comfortable. Coming to RGP lenses, the size ranges from 8 to 10 millimeter in diameter in patients with irregular topography and steeper cone, and they are more difficult to achieve a comfortable fit. Both the dynamic and static fit should be assessed, and they are ideal for usually smaller cones. So 80% of the patients survive without cornea transplantation for 20 years beyond initial diagnosis, and it has been studied that 65% of the patients were wearing RGP lenses at the time of enrollment in collaborative longitudinal evaluation of keratoconus study. The Rose K lens design is a fully flexible lens that works well on early to advanced keratoconus patients, and the power we have available is minus 30 diopters to plus 30 diopters. And the total number of trial lenses are like 26, and both corneal and intralimbal lenses are available. So coming to fitting philosophy in keratoconus, we have to take care of apical clearance, apical bearing, and 3-point touch. For RGB fitting philosophies, we have to take care of 3-point touch design, which is most popular. It usually distributes the weight of the contact lens evenly between the apex of the cone and the superior and inferior peripheral cornea. And they are best for small central cones. Apical clearance is when the lens vaults the apex of cone and rests on the paracentral cornea. So there is minimal trauma to the central cone. And in flat fitting, the entire weight of the lens is on the cone only and the edges are off. The corneal aberrations can occur in these kinds of fitting. So there should be a balance between apical touch as well as stability, and certain amount of apical touch is needed to be tolerated in KC patients to provide stability over the cone. So coming to all the fitting steps, do refraction, record best corrected visual acuity, do keratometry and topography, perform a slit lamp examination, select the best trial lens, evaluate the fluorescein pattern to achieve a good fit. There should be a central touch of 2 to 3 millimeter and a thin band of touch at the lens periphery. We have to review the centration and the movement within the blink, and doing overcorrection is best suited and before finalizing the power. Then we have RGP intralimbal lenses. They are slightly larger than the corneal lenses and slightly smaller than the corneal diameters. The diameter is usually from 10.5 to 12 millimeter, and they are indicated in moderate keratoconus. Then we have scleral contact lenses. They are further classified as corneoscleral, semiscleral, miniscleral, and full scleral lenses. So the corneal ectasia that cannot be fit with other form of contact lenses requires scleral contact lenses, and the lens sag must be greater than the corneal slope in order to achieve this type of fitting relationship, and it is usually indicated in patients with advanced keratoconus. So they have advantages of better comfort, less mechanical trauma, and better vision. Then we have PROS, that is prosthetic replacement of ocular surface ecosystem. It is a customized prosthetic corneoscleral device for each patient's condition and unique eye shape. So an expanded artificial tear reservoir is formed that provides a constant lubrication while maintaining the necessary oxygen supply also. Then we have piggyback contact lenses, that is 2 lenses on one eye. The RGP lens piggyback is placed on a soft contact lens. They are usually indicated in irregular corneas where RGP lenses fit is not possible, such as keratoconus, PMCD, post-graft or post-LASIK ectasia. So popping out of the lens can occur at 3 and 9 o'clock staining with RGP fit, and also in the presence of scar. Then we have hybrid contact lenses. They have a rigid gas permeable center and a soft skirt. There is optimized lacrimal lens. The optics is centered over the visual axis despite the location of the cone. And the wall design is such that it clears the vast majority of the ectasias with significantly flatter base. Then we have custom wavefront guided soft contact lenses for post-operative corneal ectasia. Coming to tandem contact lenses, they are composed of a soft silicone hydrogel lens that is fitted between a RGP lens and cornea, and they have very good comfort as well as fitting. These lenses can be used initially as lens adaptation or they can be used later on as long-term management also. So the practical tips for early cones, we should start with RGP or rose-K contact lenses. For advanced cones, start with the lenses of smaller diameter like 8.7 millimeter with a steeper base curve. And for proud nebulae, in such cases, both the raised surface can be treated with either with superficial keratectomy or excimer laser, and the patient can restart the contact lens wear. So here, in addition, we can give hybrid and scleral lenses. And after collagen cross-linking, usually the patient are asked to continue with their own lenses, and later on, when the topography or power changes, they can be asked to change the lenses accordingly. After keratoplasty, one may use a larger diameter lens such as intralimbal lenses, and after intracorneal rings, they usually improve the corneal surface topography, and they also help in the fitting of RGP lenses. In keratoconus with corneal dystrophy, if the visual acuity is not explained by the opacities in a patient, then one should consider keratoconus and perform the contact lens trial again. So for Fromifraste, we usually manage with spectacle correction. For early keratoconus, we use RGP lenses, and for moderate keratoconus, again RGP lenses, and in severe, we can use scleral lenses. Thank you.
Thank you, Dr. Anu, for a wonderful talk.
Hello. So Anu, I have a question for you. So, in your experience, how you rate rose-K versus scleral lenses?
Sir, for the patient comfort, like rose-K are more.
Rose-K are better lenses.
Better lenses.
And what about the wearing schedule of scleral lenses? How you explain how many hours he should use the lenses, scleral lenses? 12 hours, 8 hours, or some wearing schedule for these patients, or they can use full day?
So they can use full day. Like patients are not comfortable
Okay.
usually with the scleral lenses.
Mhm.
There is one with the softer skirt. They are more comfortable with that, but not with all scleral lenses.
Yeah. Okay. Thank you, Anu. Thank you so much. So the next talk will be by the by Dr. Parul, and she'll be speaking on taming the bulge management of acute corneal eye drops. Dr. Parul.
Good morning, one and all. I thank the AIOS for giving me this opportunity. So I'll be speaking on taming the bulge, management of acute corneal eye drops. So we start with the case. So this was a 24-year-old male with chief complaint of diminution of vision in the left eye for 2 weeks. It was sudden in onset, associated with whitish opacity in the eye, pain, redness, and watering. The ocular examination will be discussed in the photographs. This was the left eye with the acute corneal eye drops, and this was a right eye with the healed eye drops. So diagnosis was bilateral advanced keratoconus with amblyopia. He had nystagmus in both eyes and very poor vision, with right eye healed eye drops and left eye acute eye drops. So what is corneal eye drops? It is estimated to occur in 2.6 to 3% of the keratoconus patients. Most of the cases are seen in the second or the third decade of life. Men are affected more, and there is no racial predisposition so far. Etiology can be primary corneal ectasia like keratoconus, PMD, keratoglobus, and TMD. Secondary corneal ectasia like post-refractive surgery or post-keratoplasty, or other ocular pathologies like infantile glaucoma and forceps-assisted deliveries. What are the risk factors? Eye rubbing is the most common risk factor and the most important, so we advise all our patients to avoid eye rubbing. Then VKC, atopy, Down syndrome, steeper keratometry at presentation is also a risk factor for eye drops, and poor visual acuity at presentation and earlier age at onset. So what is the pathogenesis of acute corneal eye drops? The torn Descemet membrane causes the rolling of the edges, and a gap is created. Aqueous from the anterior chamber percolates into the corneal stroma. There is separation of the collagen lamellae and formation of large fluid-filled stromal pockets. The DM may retract to form scrolls, ridges, and strands around the attached fragments of the stroma. There is spontaneous approximation of DM to posterior stroma may occur, and it depends on the depth of the DMD. Endothelial redistribution over the intervening area is done and depends on the dimensions of the DM break again. Resolution of corneal edema may occur any time between 5 to 36 weeks, may leave behind vision impairing scar. So what are the clinical presentation? There is sudden loss of vision, marked epiphora, intense photophobia pain, and antecedent episode of vigorous eye rubbing or coughing. A slit lamp examination usually reveals marked stromal and epithelial microcystic edema, intrastromal cyst or clefts, and conjunctival hyperemia. What is the grading? Grade 1 is within the 3 mm diameter of a circle, grade 2 is up to 5 mm, and grade 3 is more than 5 mm. So complications can be increased. When there is an increased area of corneal involvement, there can be increased risk of neovascularization. There can be increased risk of endothelial graft rejection subsequently. There can be infection, pseudocyst formation, malignant glaucoma, and corneal perforations. So this was our patient with a thickness of 1.8 millimeters, that is 1800 microns plus, when they presented with the eye drops. You can see the intracorneal fluid clefts also in between, and you can see a break in the DM and the separation, that is a rhegmatogenous DMD. This is the other eye, which is a case of a healed eye drops. You can see the thinning and the scarring. This was the pentacam of the right eye. So AIOS20, it shows intrastromal clefts as in our patients, size of the break, corneal thickness, and the depth of the DM detachment. So AIOS20 shows us DM detachment with breaks and rolled edges, break with flat edges, and no break at all, or a taut DMD. So increased epithelial thickening, stromal thinning at the keratoconus cone, and hyperreflective Bowman's membrane are all risk factors for corneal eye drops. So you can see in these pictures, before eye drops, we have a hyperreflective Bowman's membrane in the first group of pictures, and acute eye drops, these patients develop acute eye drops subsequently. So what is the management? Early management is essential. Spontaneous resolution of eye drops without any intervention takes around 5 to 36 weeks. Increased duration of corneal edema leads to increased risk of corneal complications, so warrants early resolution of eye drops. So what do we give? Conservatively, we give topical hypertonic saline 5% to reduce the intrastromal edema, topical corticosteroids to reduce the inflammation and prevent neovascularization, cycloplegic agents, topical lubrications for comfort, and pressure banding and bandage contact lenses. What are the surgical options? Pneumodesmetopexy and compression sutures. AMT can be done if we cauterize the stroma, and tissue adhesives can be used if there is a perforation, or we can also go ahead with penetrating keratoplasty or DALC or lamellar keratoplasty. And some authors have even mentioned a mini DMEC, 5 mm punched out DMEC, which is applied, 3 to 5 mm. So what we gave in our patient, we gave antibiotic, lubricants, atropine, timolol, sodium chloride 5%, and prednisolone 4 times a day. And we did a left eye desmetopexy with intracameral 14% C3F with compression sutures. So this was the pre-op visual acuity, 1800 micron thickness. And in the post-op day 1, you can see how much the corneal edema has subsided. You can see the air bubble, that is a C3F bubble actually. And you can see the compression sutures which have been applied perpendicular to the break. So you can see the drastic decrease in thickness even at the first post-operative day, that is from 1800 microns to 600 microns. Then this is the post-op 1 week photograph showing a thickness of 523 microns, post-op 2 weeks photograph showing an even further decrease in thickness. So pneumodesmetopexy shortens the period of corneal edema. The agents that can be used are air, 20% SF6 or 14% C3F8. So what is the technique? Preoperative pupillary constriction is done with topical pilocarpine, 2%. AC paracentesis is done to decrease the pressure subsequently, and we aspirate 0.1 ml of aqueous humor. Then we intracamerally inject air, C3F8 or SF6 to fill 2/3 of the anterior chamber. Then we make a peripheral iridectomy, and we advise supine position for 2 weeks and topicals. So we can also give a topical mydriatic agent at the end of the surgery to keep the pupil dilated and avoid the pupillary block. So that is what we did in this case. We didn't do a peripheral iridectomy in this case. So what are the complications? Pupillary block glaucoma, intrastromal gas migration, which leads to the formation of fish eggs, endothelial cell loss, cataract, and Urey-Zavalia syndrome. So compression sutures. Sutures bring the edges of the break closer together and hasten the resolution of edema. It reduces the recovery time, especially in the presence of large stromal clefts. So these are the full thickness sutures, or we can also put a pre-desmetic suture. In this case, we put a full thickness suture. But we can also put a pre-desmetic suture, and that also does the work equally well. So we injected intracameral air to visualize the DM and bring the DM closer to the stroma, and then 2 to 5 pre-desmetic or full thickness sutures. We did a full thickness suturing with 10-0 nylon were applied perpendicular to the tear, starting 1 to 2 mm from its edges. And sutures should be ideally removed within 2 to 6 weeks. So this is how we mark after putting a bubble the edges of the DM, and then we apply the sutures perpendicular to it. So the air bubble helps in visualization of the DM scroll very nicely. So another technique, triple technique, has also been illustrated in literature. That is OCT guided puncture, venting incisions we give, intrastromal pockets we make, and then we do a AC air fill, and we apply pre-desmetic sutures. This is only for very small DM defects. So case number 2 was a 42-year-old female who presented with the similar complaints. Left eye showed this picture. We did a microscope assisted OCT guided left eye desmetopexy with intracameral C3F8 and compression sutures. So you can see that initially it was 922 micron, and subsequently post-op it was 595 microns the corneal thickness. And you can see the bubble, C3F8 bubble, is not too large, so you fill around 2/3 of the AC only and apply the compression sutures perpendicular to the break. So this was finger counting 3 meter at post-op 6 weeks. You can see how beautifully the cornea has cleared up, and the corneal thickness has become physiological, that is around 522 microns. So what is the take-home message? Early recognition of risk of acute eye drops, like we showed the Bowman layer reflectivities in the AIOS20 photographs, is very essential. Patient risk factors like VKC, eye rubbing can be managed, and we should counsel the patients. If there is a high risk of eye drops, early surgical intervention is advised. Dr. Susan Jacob has also advised a pre-desmetic DALC, in which she uses a 26 gauge needle, bevel up, and induces tissue emphysema in the anterior portion of the eye drops area, and then manually dissects the corneal stroma. and they give beautiful outcomes. So conservative medical treatment can be started and based on the size of DM defect, presence of fluid clefts. Surgical intervention includes intracameral gas tamponade, puncture and drainage of the fluid pockets, and compression sutures. Use of MIOCT as an adjunct can be used intraoperatively, and penetrating keratoplasty can be done for very large DM tears, more than 2 mm. Thank you so much.
So, very nice talk, Dr. Parul.
Thank you, sir.
So, Dr. Parul, in compression suture patients, so for how long you continue the cycloplegics?
So for around 1 week,
1
not
week,
more than
yeah.
that.
Because gas is in the chamber, you put full chamber gas, na? At the end?
Two-thirds, sir, two-thirds.
Two-third, movable.
Yes, sir, movable.
Okay, okay.
Yes, sir.
And about the sodium NaCl?
Anesthesia? So
No,
we
no,
do
NaCl.
NaCl we continue throughout.
Continue.
Yes, sir.
And okay. And what about the suture removal? When you remove the sutures?
So it's mentioned in literature that 2 to 6 weeks. We can even go beyond that.
Because I removed suture in one patient at 6 weeks,
Yes, sir.
and after one week of suture removal, patient again developed high drops.
Exactly, sir. That's what I said, because I also encountered the same thing in one of my patients. So in literature, it is mentioned 2 to 6 weeks.
So
but
now I
ideally
remove
we
at
can-
least 3 months.
3 months, exactly.
At least 3 months
Yes,
later.
yes.
So that will be the better approach.
Better option,
Yeah.
yes, sir.
Okay. Anything, Anu? Thank you, Dr. Parul.
Thank you, sir.
So I think next Dr. Sharon, Dr. Purvasha not here still, so I'll present my talk. ठीक है. Mic.
Ma'am, we use peribulbar block.
Excuse me. चला दे. Thank you, Dr. Parul and Dr. Anu, for including me in this Keratoconus instruction course. And I'll be talking on corneal transformation, advances in the management of keratoconus. So as Dr. Sharon was supposed to present surgical management and DALC, so I'll be starting from her talk. So I frequently do femto-DALC in all my keratoconus cases. So we have Zimmer's Z8 machine. So this machine has a proprietary DALC software. So in DALC, the main challenge is to get a big bubble, because you're not sure whether you will get a big bubble or not. So with this software, what you can do, this has an intraoperative OCT also. So you can take a picture of the OCT during the surgery and create a tunnel in the posterior stroma, depending on the thickness. So like we have removed 350 micron of the cornea, and then from the remaining cornea, you can go create a tunnel and go up to 30 micron. And once the tunnel is created, now the surety of getting big bubble is very high. So just see this video. We have cut the cornea, stroma, and this is the tunnel created by the femto laser. And once the tunnel is created, you have to use Foglas cannula to inject the air in the tunnel. And the procedure becomes very simple and predictable. So you have to go inside and inject the bubble. And success rates are very high with the femto-DALC, and then suturing is done. So coming to the next procedure, that is stromal expansion. So in keratoconus, the main problem is thin cornea, problem in contact lens fitting, and cornea not fit for cross-linking, so you cannot stop the progression. So in such cases, stromal expansion is a wonderful technique by which you can tame all these three problems. So this is a Visumax machine on which you can do this procedure. It's as similar as smile surgery. You have to create the lenticular pocket, remove the minimal stroma, which is because you have to remove something, so at least 10 or 12 micron, remove it. And this is the donor lenticule, donor smile lenticule from the patient. So usually I prefer to use at least 120 or 130 micron donor tissue, and simply you have to push it inside. The procedure is very simple. There is no learning curve. You have to push up to the extreme opposite end. It should not come in the wound. And once you make sure that it is nicely settled, unfold it, and the procedure is done. So you have added the tissue. Now the next goal is to do the cross-linking in such cases. So once it's done, you can gently peel off the epithelium because the tissue is very soggy. You can remove it with the simple sponge. You don't need to use the knife. And you can see how easily it is coming out. And once that, so there is a nicely sitting lenticule inside. So you've increased the thickness. So now it's a thicker cornea, and you can do the cross-linking, so it won't progress also. And it induces flattening also. So the post-operative best corrected visual acuity also improves, and contact lens fitting also becomes easier. So this is a post-operative picture. The lenticule is nicely sitting, no haze in the stroma. Coming to the next treatment option in keratoconus is the topo-guided PRK with cross-linking. As we know, the cross-linking is the standard of treatment for preventing the progression of keratoconus. So if we have good preoperative thickness in many cases, so we can combine with the topo-guided PRK. So by this, we are flattening the cornea, we are removing the aberrations, and as it is topo-guided, so aberrations will be less, and you can reduce some cylindrical error also. But the limitation is that you should not go beyond 50 micron ablation. So in 50 micron, you can reshape the cornea as well as reduce the astigmatism. So by which you can get the good visual acuity along with the keratoconus progression arrest. And the protocol is that expected corneal thickness after this procedure should be at least 400. You should not go beyond that. The next augmentation procedure for keratoconus eyes are intact rings or intercorneal ring segments. So these are the PMMA segments, and it comes in different sizes, and you can combine based on your need or on the patient's profile, cornea profile. So it basically works on the principle of arc length shortening, which means the outcome is directly proportional to the thickness of the implant. So if you put thicker implant, the flattening will be more. It comes in two designs, regular rings or SK rings. And these are the prerequisite for intacts in keratoconus. The first, the central cornea should be clear, because if there is an apical scar or a haze in the center, you won't get good visual acuity. Contact lens intolerance. So the first option is always contact lens, as Dr. Anu mentioned. But if we are not able to fit the contact lenses, and because the cornea is very steep, you can flatten it with the intacts and then go for the contact lenses. Results in very steep corneas, more than 60 micron, more than 60 diopter, the results are not very predictable. So the best patients is from 52 to 58 diopter range. And the last is pachymetry should be more than 450 micron in the location of intact. So location is usually 6 to 7 millimeter in the cornea. So in that area, at least you should get 450 micron thickness. So these are some of the parameters for planning intacts: location of the cone, mean refractive spherical equivalent, mean K value, superior inferior asymmetry, steep axis, and the thinnest point in 6 millimeter zone. So these are the protocols that we learn at Narayan Netralaya from Dr. Rohit, and we plan our intacts ourselves. We don't rely on the company's nomogram. So the locating cone is very simple. Just you have to see the steep point. If it is in the central 3 millimeter, it's a central cone. If it is outside 3 millimeter zone, it is a decentered cone. The next is MRSE. The spherical plus half cylinder gives you MRSE, and based on MRSE values, you can choose your rings. The mean K value is here in the pentacam, and if it is less than 55, then regular rings works well, and if it is more than 55, you can go for SK or thicker rings. Superior inferior asymmetry. So difference. So how to calculate this point? If the difference of mean of superior 3 contiguous points in 3 millimeter zone to diagonally opposite 3 millimeters zone, if it is more than 15 diopter, then you should use single ring. If it is less than 15 diopter, then asymmetric rings works very well. Again, the axis location from where you should insert your intact rings. So it should be at the steep meridian, OpScan, pentacam. You can use any device. And sometimes with the OpScan or these topography, they shows the steep axis nasally or inferiorly. So in such situation, you can go for tangential method. So how to find the axis and the tangential method? You have to draw a line towards the direction of the cone, and then draw perpendicular to that. Then you will get a steep axis. Incision depth. Then mark the 6 millimeter zone, and take the 75% of the thinnest pachymetry at 6 millimeter zone, and that will be the plane in which you are going to put the Intacs rings. These are some of the instruments used for Intacs. So I prefer to use femto Intacs because many people are now doing femto only, and you have to create a channel with the femto machine. This is a Zimmer machine, and once the channels are created, you have to open the channel. So this is a channel opener, which is V-shape. You can open both the sides with the same instrument. You have to go vertically first and then horizontally along the cornea plane, and then you have to insert the rings. Inserting rings is very easy. The problem is holding the rings because slippage is very high with the Intacs rings. So you have to be very careful. You should not hold very tight and not very loose also. And always push the ring towards the opposite extreme. Never leave at the wound because it can migrate out. Okay. So these are some of the cases in which we have put Intacs. So you can see there is a central cone. We have put 2 symmetrical rings, and from 55 it is now 44, and the K1 K2 decreased from 59.5 to 55.8. Almost 4 diopter flattening was induced with this Intacs. And this is a decentered cone case in which we put a single ring, and you can see the flattening from 47.4 to 44.3. Again, 3 to 4 diopter of flattening. This is a asymmetric cone in which we put the asymmetric ring, and flattening from 44.2 to 41.4, again 4 diopter of flattening. So Intacs is always combined with the cross-linking procedure, and because cross-linking arrests the progression of the keratoconus also, and it induces more flattening with Intacs. Intacs is flattening, again 0.5 to 1 diopter. Cross-linking is also flattening, so the result will be better. And although it has some complications, like vascularization of the incision site, melting at the incision, you have to put sutures in that case, deposits along the Intacs rings, which usually improves with the steroids. And so this was one case I did last month in which there is a Kerr ring inside the eye, and you can see the vascularization and melting along the Intacs ring. So I removed this ring and then treated the patient topically, and eventually the patient heals. So we have to be very careful while managing these complications. And this is again another case in which the ring has migrated outside the incision, and it needs to be explanted. Explantation is very easy. Again, you have to take a dialer or any such instrument and put in the dialing hole and take it out along the direction of the placement of Intacs. So it's removed like this. So the new thing in keratoconus is the CARES, done by Dr. Susan Jacob mainly, and this is a new innovative technique in which instead of using plastic ring segments, donor corneal tissue strips are inserted in mid-peripheral zone of keratoconus cornea to cause its flattening. Although this is a very good technique, but again, because this is a corneal tissue, so risk of rejection, risk of infections are higher than the Intacs. And as these segments are more biocompatible and less rigid in comparison to plastic ring segments, so we are not sure after 5 or 10 years how they will behave, whether they will flatten more or their effect will go off. And the main difference between Intacs and CARES is that Intacs is a reversible procedure. You can remove the Intact segment if you don't get the good results or anything happens. But with CARES, it integrates so well with the cornea, its removal of CARES is almost impossible. Thank you so much.
Thank you, Dr. Bhupesh, for an excellent talk and the excellent videos. Now we move on to Dr. Sharon D'Souza, Sculpting Clarity, Surgical Options in Keratoconus.
morning, everyone. Right, so excellent set of talks and very comprehensive talk by Dr. Bhupesh. So we sort of decided that to try and avoid an overlap, I won't be talking about all the surgical options in keratoconus. Bhupesh has covered quite a few. I'll be talking mainly about DALC because PK is something which, there are a lot of, it's fairly simple in that sense. So we'll move to DALC. And the first question is, why would you prefer to do a DALC in these cases? Of course, we know there's a very reduced graft rejection risk as compared to a penetrating keratoplasty. It has a great wound strength with, if you are well versed with it, then less risk of intraoperative complications. Of course, you can't have an expulsive and things like that. And a faster tapering of topical steroids, so the complications related to that is less. There are multiple indications for DALC, but of course here we are concentrating more on the ectasias, and those are the most common ones which we do. There are a few points which you have to keep in mind when doing planning the DALC, and this really has a very important impact on our outcomes. The first being, what is the pathology you're doing it for, because the sizing of the graft, the centration of the graft, all of it matters. The next is if there is a scarring, and it can be because you're doing it for a scar or a dystrophy, or the keratoconus itself may have a scar. It's important to assess the scar on the slit lamp, or if you have access to an anterior segment OCT, to assess that, because your planning and the type of technique you use for the DALC would change. Of course, you're looking at the size of involvement, whether it's centered, decentered, the status of the endothelium and the DM. Very, very important to differentiate between a hydrops from a non-hydrop scar, because your technique you use would again change, and I'll be discussing that. So there are a number of techniques that we have for DALC, the most popular being the big bubble technique, which was invented by Anwar and Takeman. And that's the one which is most commonly done. But of course, you get excellent results even with a good manual dissection, and we'll show that. The greatest thing about DALC, I think, is the fact that you don't really need too many new or unusual instruments in your OT. Most of the time, you can manage with everything which is available. And if you're familiar with doing the bubble with a 30-gauge needle, then you really need nothing. Probably the only thing which I think would be very, very important or useful for a person starting out in DALC is a good set of blunt tip scissors, because they are fairly invaluable, especially in the posterior dissection. Now, critical steps when we're talking about DALC is centration and marking and sizing. So include the entire cone to make sure. So if you can see the Fleischer's ring on the slit lamp, then try to get that into your entire diameter of trephination, because otherwise you can have some amount of ectasia from that cone because you left behind part of it. Avoid too much of decentration if it's a small trephination, because you can get an incomplete bubble. So just very briefly, a few steps. So we can use, for the trephination, you can use a handheld trephine or a suction trephine, it doesn't matter. But if you're using a handheld trephine, then you really need to go in with a guarded depth knife, because a key to whether you're, irrespective whether you're doing a manual DALC or a big bubble DALC, is a key is to try and get that trephination as deep as possible. So if you're doing a manual trephination, then go in with your guarded knife, depending on how thick your cornea is, and then you can do an anterior dissection of the stroma. In the technique I follow, I almost always debulk the anterior stroma before going in for the big bubble, but I know a lot of surgeons who would avoid this step completely, and it would depend. The exception to the rule is if you have a very, very thin cornea, say a 200 micron in the center, 250 micron, then avoid de-roofing the entire cornea, because then you'll not get the big bubble because there's too little stroma. So next is the big bubble. So you can use either a needle or a cannula for the big bubble, it doesn't matter. But if you're using a cannula, then you have to use something like a point dissector to make a small track. And here it is essential that you go in as deep as possible, because the cannula is a blunt tip cannula. It's not going to go in deeper than the plane you put it into. So you have to get your point dissector as deep as possible. And now we'll insert the cannula. The direction is usually central or mid-peripheral. People have shown that even if you inject in the periphery, you may get the bubble, but putting it in the mid-periphery is much more repeatable and reliable. And you can get the bubble fairly, almost always, if you just follow this. The depth, of course, would depend again on the technique. With the needle, you don't need to make a separate channel, but you do need to make sure that you're going in the mid-periphery. And here you don't want to go too deep because you may get a perforation. The next step is releasing the bubble. So once we have the bubble, we now need to release and de-roof the posterior stroma. So a few things before that. Almost always do a paracentesis so that your eye is softer. This prevents an inadvertent cut or rupture of the DM endothelium complex as it moves up as you de-roof the bubble. Putting in an air bubble into the AC after you've done the paracentesis, and this kidney-shaped bubble that you see here is that air bubble. This, first of all, tells us that you have actually achieved a bubble, and that big bubble is pushing the air bubble in the AC to the periphery. So it helps us really, especially if there's a lot of emphysema. And the minute it moves to the center, as you'll see in this video, you'll know that the bubble has been deflated. This is the brave slash. And one very, very important thing with the brave slash, if you can see the direction of the side port blade, is that we are going horizontally into the bubble and upwards. Okay, so the chance of you actually touching the DM in this process, unlike earlier when we used to do a vertical slash, a horizontal slash makes it very, very safe. And I also use a viscoelastic on top of the point where I'm going to put in the bubble so that you can see the egress of air. These are blunt tip scissors, and it doesn't matter which ones you have a micro scissors with a blunt tip, invaluable in your dissection of the posterior stroma. Go in bravely, nothing is going to happen. The tip is blunt, the edges are blunt. And the DM endothelium, because this is the pre-decimetic layer, because this is a type 1 bubble, and the pre-decimetic layer is incredibly strong. It really takes a lot to perforate it once you've got the type 1 big bubble. Okay, so you do a quadrant dissection of this and try to remove it in sections. And that is the glistening DM there and the air bubble inside the AC. And this is how you go ahead. Try to avoid leaving too much of a ledge at the periphery because that would affect your graft-host junction. So you need to get a nice vertical ledge at the periphery. Excuse me. So once you've done all of this, invariably you get great outcomes with talc. You do need to make sure that this patient doesn't have too much of VKC or other allergies because that would affect outcomes. Right? But there are always some glitches which can happen. One is, of course, especially when we are starting out, is not getting the bubble at all. You inject, you get a lot of emphysema into the stroma. This, simply put, is you're not deep enough. We're injecting into the stroma, and so you're just getting a little bit of emphysematous bubbles. So the initial trephination has to be deep, and I was discussing how you can go deeper. And if it's a cannula, you really have to make sure you're deep. If the air is coming backwards, then you're not going to get the bubble. So come out and try in a different area. The air has to go forwards, and that's when you're going to get the bubble. This was a sign that I described. And if you look at the video which is coming out, those fine little spikes are telltale that you're going to get the bubble. And this happens when you're not really as deep as you actually should be. It's somewhere midway. But unlike, I said you shouldn't get too much emphysema, don't stop if you see those spikes. Keep injecting and you're going to get the bubble. And how is it different from the earlier one where you see you're just getting a spot of, clump of emphysema? There's no spikes there. You're not going to get a bubble. Even if you inject, you'll just become a total emphysema. Now, what if it's a scar like this? In these cases, I would suggest not to try for a big bubble. You see, it's a full thickness scar. And even though this is not a high drop scar, if we try for a big bubble here, there's a high chance of getting a type 2 bubble, which then leaves behind just the endothelium DM, which is a much, much more fragile layer, and you're likely to develop complications. So here you can go ahead and do a near decimates manual dissection, and you can see that there's very little residual stroma on the anterior segment OCT. And even though there was a scar residual, this patient is still going to do well in the long run because of the lower risk of rejections. We have shown that the outcomes of manual DALC, if done well, versus a big bubble DALC, even though there's not so much of a wow factor in the initial time period, in the long run really doesn't matter. If it's a post-hydrops eye that you have to do a DALC, it does not mean that you go ahead and do a PK. You can still definitely get away with doing a DALC as long as it's not a very, very large scar. But you need to know that it's a hydrops and not try for a bubble at all in these eyes. So your dissection has to start periphery, early away from where the hydrops area is, of course. You can try various techniques of manual dissection, which I'll just show. And when you're in the area of the hydrops, the old hydrops, avoid pulling the stroma too much. You need to be very gentle. Leave behind a little bit of stroma so that you don't have a break. And if you have a break also, it will usually be a small break which can be handled. So this is just to show how you can do a good manual dissection. So again, here I'm showing a suction trephination, which you've already measured and kept. And then you go in again, as long as you go in deep enough. So here I'm taking the point dissector to again go a little deeper. And then with the blunt tip scissors, now I've already got the plane. This is already a near decimes plane that you've got. And once you're that deep, the attachment of stroma to the lower stroma is quite loose, and you can almost peel it off. You can also do the groove and peel technique, which has been popularized by Dr. Rishi Swaroop, which is a very elegant technique where you spiral around. But in this technique, you just go directly deep and go to the area, keep peeling it off. You don't need to use anything. This is what I meant. When it's a very, last part where the hydrop scar was, you don't want to pull it too vigorously. So, contrary to what we would think, I'm using a sharp dissection here, but that's just to release the fibers. So just to show you that even if you've had a hydrops, you can, once it's healed up well, you can get good outcomes even with a DALC. And this patient, if you can see, there's a large fish mouth scar left behind after the hydrops has healed. But even then, clinically, they're going to do well. You can see the scar, but they visually do very well. Last bit, just to show what we do if we get a perforation. So this is a case of manual dissection. And sometimes we get a little over-enthusiastic and a little overconfident, or there's an area of scar which we haven't anticipated. And you're dissecting. So wherever possible, avoid using sharper instruments for these cases where there's a lot of irregular scarring. And you'll see that suddenly in the middle of this dissection, which seems to be going fairly smoother, there would be a perf. I also like to keep the dissection fairly dry, unlike how we dissect a PK, and that's the perforation there. And you can see the aqueous coming out. It doesn't matter, these are small microperforations. So if it's in the periphery, all you need to do is leave behind a small patch of the stroma, complete the dissection in the other areas, and then put your donor cornea. The last case I want to show, this was a case of macular dystrophy. And some things like this can also happen when, we're using a suction trephine, where suddenly you see the fluid coming in there, and the suction trephine has gone in a bit too deep. That's okay, doesn't matter, we'll still be doing a DALC. So you suture the area which has got perforated, and start your dissection from another area, put in air to keep it well formed, and you just start your dissection from a peripheral area. And as I will show you, you can get a nice plane of the dissection. So that's the bare DM endothelium complex pre-disseminated dissection, and you can get away with a great DALC even in these conditions. So DALC is not without its complications, but most of the time if we preempt them, we can manage it fairly well and you get great outcomes. So wherever possible, please try to do a DALC and avoid PK. So thank you very much for your patient listening.
Thank you, Dr. Sharon, for an excellent talk and beautiful videos. So we come to the end of the session.
Thank you.
Thank you all for attending. Thank you all my co-instructors and all the audience for attending this session.